Oh, okay. So I can say quite a lot of people are over the age of 35. All right. So now the next question I want to ask. Before this webinar, how many people are familiar with the word perimenopause? All right. Okay. So thank you for the participation. I want to make this as interactive as possible so it's not like a one-way street. Okay, so when we say perimenopause, as in it's like a combination of words, peri, menu, pause, and the English part of it is the pause, as in you are pausing, you are stopping, even if it is temporarily or permanently, there is a pause. Then we now have the peri and the menu. So like I said, every woman who lives long enough will go through it. But why this is so common, why this cuts across all women, or almost all women, that this is not a conversation that we normally have around amongst ourselves. So we are all going to go through it as long as we live long enough. But then not many people know about it. Not many people are living in this transitioning phase. And yes, you don't know anything about it. You are not even sure what is going on with your body, and nobody is talking about it. Because why there is this silence of, especially a cultural silence. Women hardly talk about menstruation. Women hardly talk about their body. So you find out a lot of women don't even talk about this phase. Not to talk, they don't even know whether they're in this phase and what this phase looks like. So this is what we are going to do in this webinar. We are going to shed light on what the perimenopause means and how we can recognize whether we are there, or when we get there, what we're going to do to make the phase a livable one for us. So I'll be going through this presentation with this outline. We're going to be talking about the definition all the way to the symptom spectrum, and then the management. So what is perimenopause? Simply defined by the Collins Dictionary as the period of time preceding menopause. So perimenopause, peri like periphery, like the perimeter. So you're circling around. So it's a Greek word for around. So that means we're going around menopause. So it is a transitional stage in which the ovaries gradually and unevenly produce less estrogen. So perimenopause is not you can't pinpoint perimenopause. It's a transition. So that means you are traveling on a long road. Okay, for some people, it may be 4 years, for some people, it may be 8 years. So imagine you're traveling on a road of several kilometers before you get to the final point. And on that road, a lot of things are going to happen. You're going to have to go up a hill or come down to a valley and then go up again. So it's not a straight road. You're going to have a lot of hills and valleys. And sometimes you get confused as to what is going on. Today I'm fine, tomorrow something else is happening. And you can't pinpoint it. So that is what perimenopause is. So it's the years-long phase of hormonal fluctuation and changing cycles that leads up to menopause. So symptoms often start sometimes years before periods become noticeably irregular. As we go along, I'm going to explain these points, but I just want you to know that the perimenopausal phase, the transition phase, or the climacteric phase, it has a lot of names, is not a straight road. I mean, you're going to go up a hill and come down and all that. Compare that to the menopause itself. You just wake up one day and you just realize that, oh, I'm menopausal already. Because for you to have reached menopause, then that means you have to have had 12 uninterrupted months without a period. So you just wake up one day and you just realize that, oh, it's been 1 year since I last saw my menses. Oh, that means I am in menopause. And that is the end, really. At that point in time, you are fully in menopause. You are not expected to see your menses again. So anything you see after 12 years, if you start bleeding again after 12 years, that is definitely abnormal and you need to have it checked. So Unlike menopause, which like, okay, you've gotten to a bus stop. It's a switch, like you just turned off permanently. Perimenopause is a slope. Okay. So you keep, and it's not a steep slope. So you just keep going up and down, up and down. And why is that? It's because they almost like have a life of their own. So they decide they don't just go down. So they swing. And when they swing, they can spike, they can dip, and then it's quite unpredictable. So that's why it is so easy, even for the physician, to miss. And even for the woman living in it, you're so confused as to, okay, I mean, what's going on? And then you keep thinking, is it something else? Is it this? Is it that? So as we go along, I'm going to have to explain a lot of things. So this also goes to what I have been talking about. You can look at the graph and see that this just goes up and down, as in it's not a straight curve. So estrogen, which is the center point, the powerhouse, what makes you a woman, as in the estrogen is what gives us the beauty, is what gives us the shape. It's essentially what makes you a woman. So estrogen is at the center point of this phase, and it doesn't just taper off in a straight line. I mean, it's fluctuates. Sometimes it surges higher than a regular cycle before declining, and then by the time you are getting to menopause, then you know that, okay, your estrogen levels are low. And this volatility, this surging high and fluctuating is what actually drives many symptoms that we see in the perimenopausal phase. So like I said, it is a timeline. You can't pinpoint it. And for some people, it can be as short as 4 years, 1 year. For some people, it can be as long as 8 years. And then typically you notice the first signs of the perimenopausal phase in your mid-40s. So like 44, 45, 46, you start noticing some symptoms, okay? And usually the first symptoms are that of irregular cycle. But some people actually they actually enter this transition phase earlier than other people. So you see someone as early as 35 actually transitioning into menopause. So for some people, it can start as early as the mid-30s, maybe like around 35, 36, they're already transitioning, okay? And for most people, it's going to be like around that mid-40s until you get to the menopausal and to the actual menopause. And the average age of menopause, according to most guidelines, since we're in England, so we use the NICE guideline, the average age of menopause is 51 years of age. So let's go back to a little anatomy for us to be familiar. Okay, I'm sure we are all familiar. So this is the uterus. In the layman term, this is what we call the womb. And this is the inner lining of the womb. This is where, if you've had a baby before, this is where the baby develops and grows and then comes out through this vagina, if you had a vaginal delivery. Okay, and so this is the fallopian tube, and this is the ovary. Now, I said estrogen is what essentially makes you a woman, okay? But you see this nice looking ivory structure here. This is the ovary. This is what I call the powerhouse of the female reproductive system. This is where the eggs that we release every month, this is where it comes from. This is what determines central role in, okay, whether you're going to have a child, whether you're going to get pregnant easily, when you're going to menstruate, when you're going to ovulate. Okay, and then these tiny, tiny dots you see here, these are there are a lot of blood vessels, and these are the follicles. Please pardon me if I'm going to medical. You can please draw me back at any point in time. So these are the follicles that are released by the ovary. So every month, I don't want to go so technical, but every month there is this our body undergoes this tight regulation. as in nature has so designed it that this is tight, as in it is regimented. Okay, starting from the brain. So there is in the brain, there is what we call the hypothalamus. And in the hypothalamus, there is what we call the gonadotropin releasing hormone, which controls the release of this hormone, this follicle stimulating hormone and the luteinizing hormone. They are in the brain. And then we have the estrogen and the progesterone, which are produced in the ovaries that I showed earlier. Okay. So all these hormones, the FSH, the LH, the estrogen, the progesterone, there are a lot more, but these are the four major players. There is a tight loop, a feedback loop. And if you look at this graph, for every woman, for most women, there are four phases in the menstrual cycle. So you have the menstrual phase, where you actually experience bleeding, okay, when you see your menstruation, when the blood comes out. There is a follicular phase. This phase is where you have the follicles that are being recruited. These are small eggs that are being recruited. And then of all these eggs, one will eventually grow, which we call the dominant follicle, and that will eventually be the one to undergo ovulation when it gets big enough. Now, with ovulation is the fertile period of a woman. With when the sperm when sperm meets the egg, then fertilization can occur and pregnancy can occur. But when this does not happen, you are going to go through this luteal phase, because the dominant follicle that is expecting to be fertilized and did not see any sperm to fertilize starts weeping. So it breaks down, and then you start seeing all these changes that you see before the next menstrual cycle. So there is, for all these phases, there are hormones that are dominant. Now, I want you to pay attention to this line here. This is the estrogen. I think this color is teal. Pardon me if I got it over. I think this is teal. Okay. Now, look at estrogen and look at every other hormone. Now, you look at estrogen and you see that at every point in time, there is a constant level. It never dips to zero. It never goes beyond this point. So it's always there. The estrogen is always there, always has a very significant level in the body. And at one particular point in time, it's going to go very high and then dips and then rises again. And that is because there is this, look at this, should I call it orange? This is the FSH. There is a tight relationship between this estrogen and this FSH. This FSH is the one that is responsible for gathering all the follicles and says, okay, let's go. This is time for ovulation again. And then the estrogen starts rising as FSH is rising. And it gets to a point estrogen will tell FSH, it's going to send a message back to the brain. I don't need you again, so I need you to shut down your level. And then you see FSH dips again. Okay, FSH will dip. So also progesterone at the beginning of the cycle, progesterone is at near zero level. Progesterone we only start coming up after the dominant follicle starts weeping. That's the luteal phase. And that's why we call progesterone the pregnancy hormone. So all these hormones, these four hormones, FSH, LH, estrogen, progesterone, and some more, they actually maintain like a regimented cycle, is a tight feedback loop, and is what keeps us as a woman, is what makes us menstruate, is what makes us ovulate, even during pregnancy and all that, and it stays with us all through our life. So we talk about estrogen. Like I said, estrogen is what makes us a woman, and it is everywhere. We need it. We need it for our brain function because it supports our cognitive function and memory. And that's why you see women in their menopause, they start having what we call brain fog. I mean, you forget things easily. It tells with a cardiovascular head, that is our heart. I mean, because it decreases the LDL cholesterol and decreases the bad cholesterol, thereby protecting our heart. It promotes newborn production. It makes your skin shine, and we all know the effects of aging. If you have enough estrogen in your body, I mean, your skin is elastic, you look good. It improves muscle mass and strength. It improves your immune system. It protects the liver from damage. It protects the lungs. So estrogen is a must-have. It is a very vital part of our being alive. So what happens when we enter this perimenopause phase? So again, I take you back to some physiology and maybe some embryology. For a woman, all the eggs you are going to be born with are already inside you when you are in the womb of your mother. So you have, like, as a baby in the womb, you have about 20 million follicles already there waiting, just arrested, waiting for further development to occur. But by the time that baby is born, the baby is born with all that, okay? But by the time you are going to enter ovulation, you're probably going to enter ovulation with some 150,000 eggs. So you can see how many eggs you lost along the way. So imagine all the years you've been ovulating. How many ovulation do you have in a year? For some people, for most people, they are going to have more than 12 ovulation in a year. And then for every ovulation, you have a number of eggs that are released, a number of eggs that are recruited, and then they die along the way. So it's not going to grow again. Remember, I said all the eggs that you need, you would have been born with them. So eventually what's going to happen? You have a store full of money or a store full of food, and every month you're going there to take it, you're going there to take it. At a point in time, it starts reducing. And at a point in time, that store is going to be empty. That is exactly what is happening in our body. So when that big store of follicles, when they start shrinking, and it will shrink with age, it's natural, there's nothing you can do about it. The ovaries, now, they are not as responsive to the signals from the, remember I said something about the hypothalamus in the beginning. So they are not as responsive as before. So you now start having this tight feedback loop. You now start having it, let me use the word misbehaving, but the right word is to misfire, because it's like the ovary is saying, what is happening? The brain is saying you are not, and the ovary is saying, look, I have to protect myself. I have little eggs that is coming in, so just manage this for now. Oh, I'm happy this month. Okay, take this much. So it's like that. It's like you just have like not a smooth message coming again. So you now have all these estrogens, I mean, all the hormones I'm talking about, the FSH, the estrogen, the progesterone, you now have them responding differently. Now for estrogen, because I said estrogen is the most important of all of them. We have progesterone that works hand in hand with estrogen, and then we have the FSH and some other hormones. Now for estrogen, estrogen starts fluctuating. Why? Because estrogen is produced in the ovaries, okay? And the less follicles you have, the less stimulation you have, then the less estrogen that is being produced. So you just see it. Sometimes it goes up, sometimes it comes down. So it starts fluctuating, but eventually it starts declining. Okay, so when it declines, you start seeing all the symptoms that we are going to talk about. But for the FSH, because there is what we call the negative feedback loop. Estrogen, it's like you have a tight master and saying, I don't want you to go there. That's what estrogen does to FSH. I don't want you to go there. So FSH stays in one place. I don't want you to move past, FSH stays like, okay, master, I am listening. But when estrogen is now being depleted, is not it's being depleted and is not giving a clear message, FSH sees it as, oh, this is my time, this is my freedom, and it breaks free. Okay, and when it breaks free, FSH starts rising. It stops responding to estrogen because estrogen has lost its hold on the brain. So when you see this, it just goes up, and you just the follicles, they do their own. It's a free town, and they do their own, and then everything is just everywhere is haywire, so you can't just pin anything down. And then for progesterone also, remember that progesterone is all, even during your peak period, progesterone will be low until you get to the luteal phase. So ovulation, because it's not getting all the other partners to work, so it becomes less frequent. So that's why once you cross that age, usually in reproductive medicine, we say that from 35 years of age, the chances of fertility drops. So the chances of you getting pregnant drops. It does not mean that you cannot get pregnant. Of course, you can get pregnant at any age before menopause. But what are the chances? The chances reduces. And there's this nice looking auntie that is always sitting in the center, that is not like, they we call the AMH, that's the anti-Mullerian hormone. It doesn't have a mood swing. It just goes. Is a one-way street for AMH. So because it depends on the number of follicles. So when the follicles are reducing, the AMH is reducing. It has nothing to do with you. So that's why we call it a reliable single marker. But we don't go around chasing it to say, okay, I want to test whether I am in perimenopause, because really your body will tell you whether you are in perimenopause or not. So all these I have explained before. This is just a pictorial diagram. I'm not going to go over it again, but know that what makes you start this perimenopausal transition from the age of 35 or from the age of 45 or from the age of 50 depends on a number of factors. It could be genetic. It could be due to the environment you're living in. It could be due to your lifestyle or some systemic diseases that will accelerate you getting into menopause. So really, we've heard about this now. How many we've seen that we don't talk about it that much, but have we asked ourselves why this silence? Is it a deliberate thing? Is it like what's it called? Is it a deliberate thing or a conspiracy theory against women, or what? Why the silence about the perimenopausal phase? Why are we not talking about it? And it's so simple. Like, a lot of studies have been done, and there is this postmenopausal patient survey that was done in UK that found that 94% of women who are postmenopausal, who are already in the menopausal phase, they were surveyed. They asked them questions, and they said they don't really know about this. They just know that, okay, they are going to enter this menopause, but it's not like it's the topic that is taught in school. And then they were like, okay, so maybe the patients don't know anything. And then they started talking to the doctors as well. And it's shocking that about 1 in 5 doctors graduating OB/GYN, not just doctors, really, about 1 in 5 of them did not receive any lectures about menopause. And then about 30% of people in the residency programs do not have a dedicated menopause curriculum. So I'll go back. When I was doing my residency, that was nothing like a menopausal clinic or anything. We deal with the problems. We deal with the problems that come. But we don't have a dedicated clinic. We don't have a dedicated curriculum. And then, we do presentation every week. So what I really knew about menopause, apart from reading, depended on those and presentation. One of my friends presented the topic, and she did a very good job of it, and it just stayed in my head the way she presented the menopausal symptoms and everything. So and that was it. That was all. So you can imagine. So if you go to a doctor and you think that this doctor is gaslighting me, or doesn't understand my symptoms, or it doesn't really know what is going on and all that, maybe it may just be that even the doctor you're going to meet does not have the requisite training about this phase, this perimenopause phase. And you can't really say, okay, oh, that is bad training and all that. Things are changing now. Now we are having doctors that are dedicating their life, dedicating their profession to menopause. So you are seeing people that are specializing in that and taking care of women, the symptoms that are already discarded, women that have been gaslighted. People are seeing them now. We are talking about it now and all that. So things are improving. So what are the symptoms of this perimenopause phase? Can we say exactly that, okay, because I am feeling this and that, I am already in the perimenopause phase? It's actually very difficult, okay? Because some of the symptoms you will experience in the perimenopause phase are symptoms that can be due to something else. If you are stressed, of course, you will have fatigue. If you have anxiety disorder, it's going to be there. You could have irregular period from a lot of things. It could be from thyroid disorder. It could be from anything. But these are also the symptoms of the perimenopausal phase. So it becomes like you really have to have a high index of suspicion and know what to look for you to say, okay, I think you are in the perimenopause phase. And it's not, testing is not going to help you because the hormones fluctuate. Remember, I said they are just like a roller coaster. The hormones fluctuate a lot, so you can't pinpoint. You can assay a woman's blood today, and you say, oh, your FSH is high, your FSH and LH is high. I think this is what is going on. And then you do it like in the next month or 3 months' time, and it's normal. You understand? Because they are just like going up and down, going up and down. So you don't have a specific thing to pinpoint it. So I would say, what are the symptoms of the perimenopause phase? So there are a myriad of symptoms. There are a lot of symptoms. And you can see, just looking at this, you will agree with me that these are non-specific symptoms. Yes, a lot are non-specific, but there are some symptoms that are specific to the perimenopause phase, and I'm going to emphasize on that. So I'm going to talk about depression, the brain fog that I talk about, as in this temporarily forgetting something. You're like, where's my key? You dropped this here. You can enter a room like 3 or 4 times, and you're like, what am I looking for? But these are temporary symptoms that disappear over time. This is way different from dementia, which is a permanent loss of the brain cells. Okay, sometimes the woman is panicky, there's difficulty concentrating, rage. I mean, you're just in a bad mood. And sometimes I wonder, growing up or working, people tell you, if you have a female as a boss, female bosses are difficult, they are that, they are this. And I'm wondering, because this phase actually coincides with the peak career level of most women. I'm wondering, could it be that this difficult boss is going through the perimenopause phase or the menopausal phase and all that? Because if you look at it, you have anxiety, you have irritability, the memory problems, mood swings, you have repeated urinary tract infection. Sorry, excuse me. There can be vaginal dryness, heartburn, a myriad of symptoms. There can be low libido. The sex can become painful, osteoporosis. And it is interesting to note that all the symptoms listed here as perimenopausal symptoms are also the symptoms you are going to experience in menopause. And it is also important to note that not all women will have these symptoms. You can have one of them, you can have 2 of them, you can have some of them. We are all different. We are all genetically different. We live in a different environment. We can have some of these symptoms. And even if we have similar symptoms, the degree or the severity of the symptoms vary from individual to individual. So saying that there are a lot of women in their 30s and the 40s in the audience, I want to ask, I'm going back to these symptoms. I want you to take a close look at all these symptoms and indicate in the chat box if you are going through any of the symptoms. You don't have to tell me exactly what the exact one you are going through, but just go through it and then you can just indicate in the chat box, oh yes, I have some of these symptoms, for the women who are over 35 years of age. Can we have the answers coming in? How many women are experiencing 1 or 2 or more of all these symptoms that I have listed here? Okay. Okay. Interesting. Okay. All right. So Yeah, keep it coming. Keep it coming, please. Okay. So how many have seen the doctor for any of these symptoms? How many have had these symptoms so severe that they have to visit the doctor? How many, please? Okay. Nobody? Why? This is interesting. Oh, sorry. So, um, why are we not seeing the doctors? We feel that this is not serious enough for us to see, or it's a woman's symptoms. I mean, really, this is something that we can manage or something. Really. Okay, so let's move on. Of all the symptoms, I want you to pay attention to this word here. This hot flushes or hot flashes. This is the most common symptoms of the menopause or the perimenopausal phase. These hot flushes. And as many as 75% of women will experience these hot flushes in varying degrees. Some may have mild symptoms, some may have severe symptoms. I mean, have you ever seen a woman, you are talking to someone, and all of a sudden, for people who are white skinned or who are very fair, you just see them, you see this redness on their face and their neck, and then they start sweating profusely, like it's something really profound. You just see them sweating, and you're looking around, you're wondering, maybe the temperature is still like maybe it's 4 degrees or 5 degrees, and you're wondering, why is this person sweating so much? That is the hot flushes or the hot flashes, like you will call it. As in, you have this sudden flare of intense heat, sweating, and you just, as when I was growing up, I saw my mother experience as in one on one, and she drenched in sweat. But really, I didn't know anything about it, and nobody was talking about it. I'm sure she didn't know what was going on. She just knew that she wasn't feeling good, and then it can be really, really quite intense, and it's really uncomfortable. And like I said, about 75% of women will experience this. This it's a huge thing where you have it in up to 3 in 4 people. And then it can be mild in some people, it can be really brief in some people, it can last for a short period of time in some people, it can last for several years in some people. So, but it can be severe enough that it actually affects the quality of life of a woman. Okay. And then, you're trying to like, this is you struggling with the realization that, oh, I think you're transitioning into menopause, and then you're having all these symptoms, and you're trying to understand your body. This is like a new life. You're trying to understand your body, things that you could tolerate before, you're finding it difficult to do, things that you could do easily before now becomes difficult. Probably before, once you hit your bed, you've gone, you slept. Now you're finding it difficult to initiate sleep or to maintain your sleep and all of that. So this is where the hot flashes come in, and it can be so disruptive. And it has been found out that, okay, there are some triggers to these hot flashes, and how do you avoid it? For someone like me who lives in this region right now, temperature is ranging between 48, 46, 48 degrees. So I am living in a hot environment. So if I am in the menopause phase, so that means I'm not going to go out, because once I enter that hot environment, that weather, then it starts. That's a trigger. So it starts. I start sweating profusely. Or if I'm the one that likes spicy food from before, or like I can't take my caffeine like I used to. You are trying to adapt, you're trying to change the way you are living so that you can have a better quality of life. That's what the hot flashes does to people. And really, it's a whole loop, what the body can tolerate. Like the brain, again, actually regulates the body temperature, so that when there is a rise in temperature and all that, the body regulates it so that you don't feel it that much, okay? But because the estrogen level is falling, okay, it shrinks. The brain cannot tolerate that range of heat again. So any small change in temperature will trigger this hot flash we're talking about. And I particularly picked this hot flash because it's the commonest of all the symptoms. It's the most common. It's what a lot of women are going to experience in varying degrees. But this, the perimenopause phase goes beyond the hot flashes, as in it goes beyond this sudden, that all more other symptoms like I've shown you before. The hot flashes, of course, like I said, is going to affect the quality of life. It's going to disrupt your sleep if you're sleeping. There is the brain fog, where you try to remember where you keep things, where you try to focus, where you're looking for a name. There is a mood shift, there is the irritability, there is this new onset low mood. You're just moody, you don't know why, and then there's this anxiety. And there is the regular cycle. Regular cycle is also a very notable symptom that occurs in the perimenopause phase. So the cycle can become shorter, your cycle can become longer, the bleeding can become heavier, or can be skipped totally. And then there is
sorry to interrupt you, Dr. Alima. We're really enjoying your talk, but we're conscious of time, and we know that our attendees have burning questions to ask you. Please, if you could wrap up within 5 minutes, we'd appreciate that. Thank you.
I will try. Okay, so why does this matter? Why do we have to talk about it? Because all these things affect your work, it affects your relationship, it affects your identity as a woman. So we need to keep talking about it as a community, in your school, as a community, as a culture. We need to open up and talk so that other people going through this can learn from you and have a level of support. So how do we diagnose perimenopause phase? Like I said, there is no test. And really, the NICE guideline in the UK has already said, for women who are over 45 and you have the typical picture, you just use the symptoms alone to diagnose. You don't have to go to the lab to say, check my FSH level or estradiol level. The diagnosis is strictly clinical. That means the symptoms that you present with. But if you find a woman who is experiencing all these symptoms and she's under the age of 45 and she's already having hot flashes, she's not seeing a period, her periods are pretty irregular, or you have somebody whose menses are stopped totally under the age of 40, or you have bleeding between periods, which we call intermenstrual bleeding, or bleeding after intercourse, which is postcoital bleeding. Those are things that needs to have a check. So don't sweep these symptoms under the carpet. Always, if you have any of these symptoms, you have to see a doctor for a proper diagnosis. So how do we manage? What are we going to do in this perimenopause phase that we find ourselves in? And the first thing is your lifestyle, which is going to go a long way to help all of us. So the lifestyle people will tell you have to have a positive social interactions. This is where you are going to have, you need to have people around you, people of like minds, people that you can talk to, people that makes you happy. Now this should be about yourself. This is a phase where you are going to be concerned about yourself, your happiness and all that. You're going to have to be managing your sleep. You're going to manage stress. You're going to have healthy relationships, and you're going to be exercising regular. And this is where you're going to pay a very close attention to your food. Okay? This is where you need to eat healthy. You need to eat healthy. You need to take a lot of phytoestrogens, a lot of food that we call phytoestrogens, like the soy, the legumes, and then you need to watch what you take. You need to do more of lean protein, take healthy fats, olive oil, avocado, and all that. So that's for your diet. For sleep, you need to have a consistent sleep-wake timing. So you make your room cool. Remember, I said that hot flashes can be triggered by a hot environment. Change your diet. You need to cut down on the caffeine. If you are taking alcohol, then this is the time for you to stop, or you take in moderation. You need to pay attention to your calcium and your vitamin D. If you can't get enough in food, then you need to have to start taking the calcium and the vitamin D supplements. And there's something we call the cognitive behavioral therapy. Or if you are into yoga or meditation, this also helps. And it's really, there's a strong evidence that all this helps with hot flashes, the sleep, and the mood. And if you are smoking, you need to stop smoking, because this smoking accelerates the deterioration of the ovaries. So the menopause is going to occur earlier, and then it's going to increase the hot flashes. So like I said, what do you pay attention to? Look at the food that you need, the high quality protein, lean protein, healthy fats, fiber-rich foods, phytoestrogen foods, and then the foods to reduce the inflammatory response, like your turmeric, your garlic, and all that. So now we are talking about, everything is about shift and shift and shift. What is the current shift in this perimenopausal management? Now, I already told you about how estrogen is very important in preserving muscle quality, muscle function, and all that. So we need to maintain this muscle function. Now, probably we've been told you need to keep working. Work for like 30 to 40 minutes for like 4 or 5 times in a week, and all that. Yes, this will work if you are less than 40. But as soon as you cross that threshold, you need to introduce what we call the resistance training. Because like I told you before, this transition phase, there's an accelerated loss of bone and muscle mass. So you need to balance it. You need to balance it up. So you need to do a progressive strength training at least twice weekly. So heavy lifting, if you're used to it, if you're not used to it, you can be doing squats, your lunges, get your dumbbells. You don't have to go to the gym. You can do all this at home. So now we go to so all these we're talking about their lifestyle things you are going to change. Now we are going to go to the medical management, because not everybody will be able to do well with the lifestyle management. So now this is the hormone replacement therapy, the elephant in the room, the one that every woman is afraid of. Don't take hormone because it's going to cause breast cancer. Don't take hormone, it's dangerous for you. You have to stop at a certain age. Don't take hormones because it's only going to work for the hot flashes, and then ABA supplements work just as well. But really, for most perimenopausal symptoms and the menopausal symptoms, hormone therapy works wonderfully. But in using hormone therapy, it is not a one-size-fits-all. It's actually the most effective option, but you have to find the right person and you have to tailor it. So you have to individualize the management. What is going to work for me may not work for the next person. And how I am going to take my hormone replacement therapy, the other person might not be suitable for the other person. So it's like you have to balance it properly. You are going to weigh the benefit against the risk. What do you stand to gain, and what are the risks? And we all know the risks that are common out there. The risk of thrombosis, which can cause stroke, the risk of having breast cancer, gallstone, dementia, they are there. Okay, but what do you stand to gain? If you stand to gain an increase or an improved quality of life, then it is worth it. And it has its benefits. It has its skeletal benefits. It reduces the coronary heart, the coronary heart disease in women, and all that. So, like I said, in giving hormone, we individualize it. The main hormones we give are the estrogen and the progesterone. And then there are decisions that we are going to make. So this woman I am going to prescribe estrogen for, how am I going to give her? Am I going to give her as a patch, or I'm going to give her as a gel or as a spray? or I'm going to give her a pill to swallow, I'm going to give her a vaginal ring tablet. Estrogen comes in so many forms. So you have to individualize it, what is best for this patient. And then also the progesterone also. What am I going to do? I think I'm better off with a macronized progesterone for it's better tolerated, or I am going to insert an IUD. Okay, and then what time am I going to start? Am I going to start at the perimenopause phase, or when this woman starts menopause, the age of 60? So these are all the everything we are going to take into consideration. And for a woman whose womb is still intact, who has not had any hysterectomy, you cannot take estrogen alone. You have to add progesterone to this, okay, so that you can protect the uterus from untoward effects like endometrial cancer. But not everybody will be suitable to take hormones. So you have the non-hormonal options like the selective serotonin, the SSRIs, the SNRIs. I mean, these are antidepressants. There is the gabapentin, or there is a CBT that I talked about. And then for women who are having the genital urinary symptoms, which is also very common, the vaginal dryness and discomfort, then you need to give the vaginal moisturizer and lubricants. As in, these ones are better tolerated because they are not, the rate of absorption into the bloodstream is low. So it's safer. You can give the estrogen, whether there is the uterus there or not. Okay. So, quickly wrapping up, key takeaways from this. If you don't remember anything, please take away these 5 things from this presentation. One is that perimenopause is hormone volatility. It is not a simple decline. It takes 4 to 8 years, sometimes longer. It is multisystemic. It affects all systems of the body because from the brain down to your toes, it is there. And then for women who are over 45, diagnosis is clinical. And then lifestyle measures, resistance training, adequate protein, sleep, and menopause-specific CBT. They are now the foundation of care. There is not an afterthought. It's something that you have to incorporate right from this moment. And then hormone therapy remains the most effective option for many with several good non-hormonal alternatives. So perimenopause isn't a malfunction. It is a normal, predictable stage of a woman's life. And the more openly we talk about it, the less hidden it has to stay for the next person going through it. So be your sister's keeper. Talk, and talk. So thank you very much for listening. These are my references. And then I'll be able to take any questions.
Thank you very much, Dr. Halima. That was very, very insightful. We've got plenty of questions and comments in the chat. Dr. Abalanle, do you want to take them?
Yeah, thank you very much for the wonderful presentation. We've learned so much from you today, and we are glad to have everyone here. We have so many questions there. Just before that, everyone could please switch on their camera just for us to take the photo, a screenshot. And we thank everyone. We have over 120 guests here with us. Thank you for joining us today. We really appreciate this. So I'll go along with the question. We have the very first one, which the person asked about getting pregnant even during the menopausal period. I want to check the question is a bit high up there. I think that was the question. So, and we have a hand up. If we could quickly take that. Lily, please, what's your question?
Yes, first of all, it's a fantastic presentation. There's a lot of learning for us. I've gone through menopause. I'm going to be 60 very soon, next birthday. But what it was when I've only heard of premenopause recently. It's quite interesting. I went through menopause, never went to a doctor, suffered. I had different suffering. I didn't hot flushes, but I was just hot all the time. But I was certain temperature, so, just a hot level. So, but I didn't have hot flushes, but I had lots of other issues. So my question is more of a side issue because I'm suffering from breast cancer at the moment. I've gone through chemo, mastectomy, radiotherapy. So I think for me, because what my understanding is I'm going through menopause again, or the symptoms of menopause again, because I don't have estrogen, because they put, that I'm on hormone replacement tablets and whatever. So it's quite an interesting thing that a lot of the aches and pains and issues which I suffered during my menopause has come back again. So I think it's just trying to understand the link between replacement tablets after cancer and premenopause, if that makes sense, what my question is.
Okay. Thank you very much. Dr. Alima, do you want to answer that, please?
All right, thank you very much for joining. Yes, so sorry to hear about your breast cancer. You're a survivor. Okay, so really, this has some of the special situation that I think I rushed through the slide. Remember, I said this hormone therapy is not going to be appropriate for everybody. So you have to individualize management. Now, depending on the kind of breast cancer, whether it is actually an active disease or previous disease, this is a decision that is not just going to be taken by any doctor. So you need like a multidisciplinary team to look at what is going to be tailored for you or to you. So for you, most likely, a lot of physicians will move away from hormones. So the non-hormonal options like the SSRIs and the venlafaxine, the gabapentins are the ones that are going to prescribe to you. And then experience these symptoms all over again. Now, you know that some, I don't know the kind of cancer it is, but you know, you have some estrogen-dependent cancer, you have some that express estrogen and progesterone and all that. And whatever medication you're giving, okay, if the medication, like if you're taking like an anti-estrogen, whatever estrogen you have left is going to deplete it further. So it's like having all those symptoms all over again. But really, it's not that you cannot be helped. You can be helped. There are other options that you can take. You need a dedicated doctor to go, and the team actually to go through this with you, walk through all this with you, and you can arrive at a shared decision as to what will be beneficial for you. I hope I have answered your question.
We'll try to go through some of the questions in the chat box. We are running over the time a little bit, but if we could stay with us for about 20 minutes extra so that we can put this together. And if we can't reach all of the questions, it'll be good for you to drop the questions for us or for Dr. Alima in the ALIBSA group, okay? It's someone said, I'm just trying to get as new questions are coming in. Is menorrhagia a perimenopausal symptom? And the first question was about someone being in the menopausal period and still getting pregnant. Those two questions, if you want to merge them, Doc.
Okay, so menorrhagia can be due to anything. Like I said, in perimenopause phase, you can have little bleeding or more bleeding. For somebody who is undergoing menorrhagia, the first question I will ask will be, when did this start? When did you start noticing these symptoms? If it is happening purely during this phase, then we need to take a close look at it and, okay, what is causing this? Menorrhagia is not a symptom you can close your eyes, so you definitely need to see the doctor, because the doctor will need to check the endometrium. You are going to have a transvaginal scan, look at the endometrial lining to see if you have a polyp or you have an endometrial, what we call endometrial hyperplasia, after probably doing a biopsy. So if you have menorrhagia, you always have to see a doctor to have it diagnosed properly. And yes, as long as you are having menses, even if your menstruation is irregular, you can become pregnant. The only time pregnancy cannot occur is when you are absolutely certain that you are in the menopause phase, and that is after 1 year of uninterrupted cessation of menses. In the perimenopause phase, you can get pregnant. So that's why we tell people, if you're not ready to get pregnant, you still have to use to continue your family planning. You do not stop until the final cessation of menses.
Mariam Malawi, could you please ask the question? Then we'll go next to Mr. Tani Martins. Mariam Malawi, could you please ask the question, please? Okay, we move to Mr. Tani Martins, please.
Thank you, Dr. Halima. I hope you can hear
Yes, I
me.
can hear you.
Yes. Wait.
Finally, I figure out why I'm having transient brain fog. So it's menopause. Um, my question is fairly not complex. I wonder what the impact of contraception are on pre or menopause. In particular, if somebody is being on contraception and they've not had the period for 12 months, is there a problem? Should people be stopping contraception at a certain age if it's having any real impact on menopause or premenopause? And should we be worried about long-term effects as well?
Okay. Thank you for that. So I think I failed to talk about this in the presentation. So if a woman is taking contraception, we have to take it into consideration when we are defining our menopause. So we say complete cessation of menses in the absence of contraception. So if you're on contraception, we do not talk about menopause if you have not seen 1 year of, if you have not menstruated for 1 year. So in that, we have other things we're going to do. We're going to check the FSH and the LH levels, and we have the time interval where we are going to do that. Is a whole complex thing for us to say, okay, definitely you are in the menopause. And for contraception affecting menopause or perimenopause, no, is actually helpful, okay? Because the progesterone and the estrogen has a protective effects and all that. As a matter of fact, some people actually use this same contraception to manage some perimenopausal symptoms. Like if you're having irregular bleeding, I have used it a lot. If you're having irregular bleeding and patients come to me, I prescribe this same contraception to regulate their menses. You understand? So it does not, and if you have not seen, if you're on contraception and you've not seen your menses for 1 year, not seeing menses for 1 year is not, I'm sorry to say, not a big deal if you're not actively looking for it. It doesn't make you sick or anything. It is the effect of the contraception. And for anybody who is on contraception, nobody gives you contraception and tells you, okay, come back in 5 years to come and have it removed. Or there's always a time for a review. So don't ever take discard the review. Go back for your appointment. Let them know. Let them check. Let the doctor see if this is appropriate for you or not.
Yeah, thank you for that. Can we have Rakia Saliu, please? Okay. If that person is not available, can we have Adewale Halabi, please?
Mariam Malawi is available.
Good day, Dr. Halima.
Hi,
Okay.
good afternoon. Good evening. How are you?
Good evening. Now, I'm not yet 35, but I'm having some of those symptoms you listed. Like my cycle has really reduced now to 26 days.
Okay.
I've noticed mood swings that I've not noticed for years back. I get tired easily, low libido, painful sex, and some
Okay.
other one that you mentioned.
First question, are you on any contraceptive?
No.
Okay. So, like I said, that all these symptoms can be non-specific. You have to look at it. You know yourself. So you have to look at your general environment. You have to look at what you're going through. Are you going through any form of stress? Do you have any anxiety-inducing things in your life right now? These are all the things, because your stress, the environment, your diet, everything affects menses. But this is a whole lot of symptoms. I would advise that you see you go in for a check. Really, you should go in for a check. Not because of the menses reducing to 26 days. I don't know. You are allowed to have like a duration of like 7 to 9 days. Okay. So not because of the menses reducing, but because of the other things, the mood swings, the tiredness, the reduce libido. There may be other hormones responsible for that. Your thyroid has been checked, the cortisol level has been checked. So you have to see a physician.
Yeah, thank
as soon
you
as
for
possible.
that. And this has been answered already. I think. Thank you so much for this dedicated presentation. What role does family planning play in perimenopause, considering its progesterone influence, like the implant?
Yes, I think I have answered that. Like it has nothing to do with it. It helps.
Okay.
It helps.
And then can we have Mariam Alawiye now, please?
Yes, ma'am. Good evening, Mas. Thank you. Kudos to the presenter. My question is that since I was 50 and I'm 55 this year, I'm still experiencing the hot flash. Though it comes and it goes, but I don't know. Then I want to ask, when is it this menopause stop on women? Which age? Thank you very much, man. That's my question.
Okay, ma. You mean the menopausal symptoms? When is it going to stop? Unfortunately, you are not going to get a clear answer about that. Remember, I told you everything is a complex interplay of genetics. Okay, this menopausal hot flashes. I'm so sorry you are going through this, but it's nature. Okay, and it differs from women to women. Some have it short, some have it long. I don't know when it's going to stop. And truly, that is the God honest answer. I don't know when it's going to stop. And I sincerely pray that it stops on time. Some women will have it for like 8-10 years. They're still having these hot flashes and all that. And some women will just have it for like 1 year, 2 years, 3 years, and it's gone. So I pray that you get the relief that you want. And then you can just go through all the lifestyle medicine we talked about and see if any of them will be of benefits, if there are things that you need to change and some things you need to embrace your
We
diet.
have a question. What about Vesolitan and Elizanitant? Yeah.
Yes.
Have they better SSRI?
Yes. So really, those are I think firstly, it's a mouthful. And they are newer generation, and then there are the non-hormonal options for the hot flashes and all that. All this depends. Like I said, it's also individualized. It depends on how you're going to. There are some people that you will not give SSRIs to or SNRIs. Okay, there are some people that will not be that will not be eligible for it. And the Fesolinetant is not I hope I got that right. It's not widely available. It's not widely available, so you work with what you have. So it also works for hot flushes and some menopausal symptoms. So the physician is going to like tailor it
Thank
to
you for that.
the patient.
Are there supplements that can
Thank you very much,
supplements that can be of help when experiencing brain fog? Then we now go to after answering this, then we can have Mr. Adewale Alabi. I think that's the next question. I want to check. Yes, please answer that.
Okay, are there supplements, brain fog and all that? Well, a lot of supplements are in the market. Some, if you take magnesium, it helps with the bone and skeletal muscle, calcium, vitamin D, DHA. There are so many supplements in the market, but whether you take supplements or not, brain fog is a temporary thing. It will resolve on its own. But we need supplements. If our diet is not enough, we need supplements. We need supplements in this phase of our life. Calcium and vitamin D especially. Those are very important supplements to take.
Thank you for that. Can we have Mr. Adewale Alabi, please?
Yeah, thank you, Dr. Alima, and I really appreciate the insightful and very educative session so far. I know you've talked about the pharmacological and the non-pharmacological aspect of how women going through the menopause or those who are about to reach the menopause, how they can go about everything. My question now is very simple and very straight. I'm sorry if I have to come in as a man to ask this question. A woman cannot be going through the menopause on their own without their partners or their husband or the whole family going through the ups and downs of it. So my question now is, how can men really support women, especially the wives or the partner, where they're going through these menopausal stages of their life, where the flushes? And you mentioned something when you said a woman can, during this period, it can be very hot or flushy or something. And if it's during winter and the woman is still feeling that hot, wants to keep the window open, the man wants to sleep in the same room when it's freezing cold, it's going to be imbalanced. So how the man is going to understand and be not separating rooms, and that is not going to impact their relationship. So how can men really support and understand these menopausal stage? Because men don't well, maybe we reach our own menopause in a way that we don't understand yet, like maybe like my other brother said the other time, that we might be having a brain fog as well. But so thank you.
Thank you so very much for the question. That's a very, I mean, I would say you are very intentional about that. That's good. So how can men help? By being educated, by having this education, by being aware, so that when your woman is going through this, it could be your wife, could be your sister, could be your colleague at work, you can recognize some of the symptoms. And also, this is, you have to fashion out what is going to work for you. If you just have to be there for her. So if she wants to keep the window open and you want to sleep in the same room, probably you just need to get more blankets and wrap yourself up while she's throwing the blankets away or something. But what we need from you is a lot of support and understanding, really, when we go into that mood, and then just be there for us, just support us. This is not the time to start like what's wrong with her. If you understand the symptoms, you know what she's going through, and then with a lot of wisdom, you'll be able to be there for her.
Thank you very much. So many comments in here. Thanking you for presenting today. And then someone just trying to say, I was perimenopausal for a couple of years. I was on implants. Guess what? My baby will be 1 next year. So that's something to complement what you've been talking about. And then
really, you can't get 100% with science. You can have that figure. Yes.
So do men also go through menopause? If yes, what are the signs?
So there's something we call the andropause in men. So like we have estrogen. We also, interestingly, women have testosterone as well, but not at the same level as the men. So the men, what drives the men is the testosterone, okay? And then their own testosterone declines slowly, I think from like the age of 40. But unlike women, they don't have the same symptoms like we do. The strength also reduces, the sexual prowess and everything. But that does not stop the fertility. Unlike women also, like women, they don't go into infertility. So you can have a 70, 80-year-old woman, a man still being able to father a child. So it's different. They have andropause, but the symptoms and everything are different.
Thank you very much for that. Amina, Imam Binuyo, and Sawat Fatima. Let's have Amina first, please, and we'll have Sawat next. Okay, can we have Sawat Fatima, please?
Yeah, thank you for presentation. That was really informative. I wanted to ask about micronized progesterone. I'm here in the UK, and I was given micronized progesterone, but the capsule is actually animal product, and it's not halal. The micronized progesterone, I wanted to ask, I mean, is there a halal option, or is it okay to take, or is so sorry, I don't know whether I should ask this question.
Yes, I understand your question, and I know where you're coming from, considering the fact that a lot of capsules are gelatin based, and we know that as Muslims. So really, this is the time for you to go back to your physician and then tell your physician, this is, I mean, read about it. You should read the contents of the micronized progesterone gelatin. You cannot take this. So there are options depending on what you're using of. But really, the other option is for you. For progesterone, you don't have as much range as for estrogen. So if you're not doing the micronized progesterone, then you are doing what we call the Mirena. That's the intrauterine system where they actually put the
sorry, I wanted to ask in your experience. Yeah, sorry, I wanted to ask, in your experience, do you prescribe micronized progesterone as a halal option, or do you?
No, we actually, so now, there are some things that you just do like really, this is what we do. This is, and you don't really look at the nitty-gritty of it, you understand? So you just go, okay, this is micronized progesterone, this patient needs it, and you're not really thinking deeply about what forms it comes in. I, for one, I have not seen a micronized progesterone before. I prescribe it, but none of my patients have come back to say this is what it looks like. You understand?
Right.
So I have no idea, really.
Okay,
I'm just going
okay.
to, right after this presentation, I have to go back, probably go to the pharmacy and
Thank
look
you,
at the form they have and
everyone.
all
And
that.
for those
Okay, great.
asking
Thank
if
you.
the presentation recording would be available, it will be available soon, and the link will be posted on the community group. Thank you. And someone mentioned andropause is even worse in men. So, so I want to
really. There's no.
So with regards supplements, what is likely?
Yes. I made that comment, sister. If you go on NHS website, there is enough research on it, and you agree with me that it affects men a lot.
Thank you, ma'am.
So, and they have many diseases associated with it.
Thank you, ma'am. We'll try to. We can all try to read more about that. Thank you for the info. So with regards to supplements, what is the likelihood of interaction with other medications during this period?
Every medication, whether in menopause or outside, there is always the risk of drug-drug interaction. So if you have a drug prescribed for you, you always have to go through the interaction, read the labels, or ask the pharmacist or ask the doctors for you to be sure whether you are even fit to take. That's why medicine is never a one-size-fits-all. It has to be individualized to you. So you have to know, I'm taking this so medication. Give the information. I'm taking this medication for my hypertension, for my diabetes. Can I take these supplements with it? And then you come to a conclusion whether this is right for you or not.
Thank you very much, Dr. Halima, and thank you everyone for joining us. We have the link in the chat box if you want to. It'll be good to have everyone join the community. Thank you. So I'll leave the floor to Alosh. Thank you.
Nice. Thank you. Thank you for listening. It's great being here.
Thank you very much, Dr. Halima, for that. That was wonderful, and that evidenced by the number of questions that we have. It was a very detailed presentation as well, which was really, really helpful. So because we have running out of time, I'm quickly going to just share this feedback form. So it would be wonderful if you could complete the feedback form, which would be included in the chat, and also we'll be share that in the WhatsApp group as well. So I've mentioned the participatory research at the start. So this is part of that. This is how we do to ensure that people from our communities that we serve are part of the research, and that means their experience are also informing research. So this is a project that we are doing with the NHS. So again, an example of what ALIBSA does. So I know you really enjoyed this webinar, as evidenced by having over 120 people, which is completely brilliant, and it has broken our attendance record as well, which is wonderful. So we hope that you will all turn back for a webinar for next month. We have Jonah Rosere talking about prostate examination and why that is needed for our community. So it would be on the 21st of September, which is a Monday, again, same time, 7 p.m. So it would be wonderful to have you all join that webinar as well. But thank you so much from ALIBSA, thank you from myself and from everyone at the team for that presentation, and also to all the people who have joined the webinar. Like I said, it is great then to see those three figures as well for the first time, I think. So thank you, everyone. I'll just
thank you very, very much.
Thank you. We'll ensure that the videos and the blogs are up in the next couple of days on our YouTube channel and also on the WhatsApp group. So again, like you've mentioned, WhatsApp group is one of our key ways that we spread the message. So please do join in if you can, and if you haven't already. Thank you, everyone.
My name is Fatiha Nei Odumosu, and I'm an associate professor of physical activity and health promotion in UWI Bristol. I founded ALIBSA, and I'm the lead on ALIBSA. So ALIBSA is an acronym from Aging Lifestyle in Blacks and Asians. It's a knowledge exchange program which is focused on improving health literacy among the ethnic minority background. So the focus is on the Black and Asian communities because that's where I'm from, and that's where the majority of the admin members are from. And we're quite passionate about reducing health inequalities based on the existing health disparities that occur within this group of people.
I'm Chang Ma. I'm a senior lecturer in public health at UWI Bristol. So my role within this ALIBSA network is acting as an admin member and also a collaborator for the ALIBSA network, and also helping to promote this network to the Chinese ethnic minority, and also helping them to have a better understanding about the importance of physical activity and nutrition. Through this network, we can spread this physical activity message to the community.
Yeah, the brain behind ALIBSA is made up of 6 admin members, which include my humble self, Alosh Jos, who is the CEO of Cricket Cube, a community-driven cricket business company based in Newcastle. We also have 2 medical doctors on the team, Dr. Giselle and Dr. Abolanle Adisupe, as well as a doctoral researcher, Oluwatobi Fatola. We have Dr. Cheng Ma, who is also a senior lecturer in public health as well. ALIBSA provides a platform whereby community members from the Black and Asian ethnic groups could be empowered through health literacy. And we feel that this would reduce health inequalities among this group of people, thereby increasing access to health services. We believe that when people are literate about their health condition, they have autonomy over their health, they are quite empowered over their health, and they have self-confidence to access health services, and that will go a long way in reducing health disparities among these communities. We will understand the barriers they face in accessing health services, and we can collectively work together to look at a well-tailored form of interventions that would enable them to access these health services. So ALIBSA is a program that helps to empower the communities. We run our monthly webinars, which involves inviting multidisciplinary group of speakers that give tailored health-related topics. And we use this platform to engage the communities on the experience with related topics. Outside the webinar, we have a robust WhatsApp community, which has over 120 members, and we do engage with our community members when it comes to resourcing health services, sharing links on ongoing research, sharing links on how to access specific facilities or resources tailored on health promotion within these ethnic groups. We also have a lot of volunteers who join us. Our webinars are well attended from different countries. This is not limited to the UK. We have people join us from other countries such as Netherlands, Canada, Malaysia, Australia, United States, Nigeria, Ghana, and several other countries. We have volunteers that also act as champions that help move ALIBSA within their home country. We do have a platform as well, which is linked with a championship and a volunteering platform, whereby we seek this platform to also mentor early career researchers who are really passionate about lifestyle-related conditions and community empowerment. Our vision for ALIBSA is to ensure that ALIBSA is global. We want to ensure that every country has an ALIBSA champion, and there will be community-driven led health literacy initiative that would help empower people within the communities. Feel free to join our network. We will strive together to empower the Black and Asian communities. We will ensure we're able to reduce health inequalities within this network.